Today we are going to talk about the second complication of cirrhosis, that is esophageal varices. It results from the portosystemic shunts and formed when the portal and systemic circulation shares the same capillary bed. In case of esophageal varices, the azygous vein tributary from the systemic circulation and esophageal tributary of the left gastric vein from the portal circulation when combined and shares the same capillary bed, then these esophageal varices are formed. These varices are basically dilated and tortuous veins. These are formed as a result of portal hypertension, as we have discussed in the previous video. The patient present as a hematemesis. Patient presents with the complaint of hematemesis or upper GIT bleeding in case of esophageal varices. In the investigation, endoscopy is the investigation of choice, and this endoscopy should be done after every 2 years. If the patient has portal hypertension or cirrhotic patient, it should be done for the screening purpose in every 2 years. Now come to the management of mortality of esophageal variceal bleeding is 45% in poor liver function patients. Now come to the primary prevention and variceal bleeding. If confirmed with the endoscopy that patient has non-bleeding varices, then give this patient propanolol, nadolol or carvedilol. These are beta blockers. Basically these drugs reduces the heart rate, and these drugs has also a vasodilating effect. As a result, these drugs reduces the portal hypertension. If the patient cannot tolerate all these drugs, that is propanolol or nadolol or carvedilol, then the second option for the primary prevention is band ligation of the variceal bleeding. If the patient is a suspected case of variceal bleed, then give this patient blood and plasma and IV fluids, that is normal saline, to normalize and stabilize the patient, and also give the patient IV terlipressin. This is a vasopressin analog and it is vasoconstrictor effect. And also give the patients broad spectrum antibiotics, that is ciprofloxacin or tazobactam and piperacillin combination, or also IV cephalosporins to prevent the sepsis and inhibits the bacterial peritonitis. Perform the urgent endoscopy. Then check if the varices are present or not. If no varices, then stop terlipressin. If varices are present, then endoscopic management or band ligation or sclerotherapy should be performed. Then check if the bleeding is stopped or not. If no bleeding is stopped, then further endoscopic program should be continued, or balloon tamponade or emergency tips. We will discuss all these steps one by one. But if the bleed stops, then continue terlipressin for 72 hours, give the patient beta blockers for recurrence or secondary prevention, and enter this patient into endoscopic band ligation program. So this was the emergency management of variceal bleeding. Now come to the pharmacological management in portal hypertension. As we have discussed previously, give the patient terlipressin. This terlipressin is basically a vasopressin analog. It reduces the portal blood flow and reduces the intrahepatic resistance. Due to this decreased intrahepatic resistance, the portal hypertension decreases. This should be given as 2 mg IV 4 times until the patient bleeding stops, and then 1 mg 4 times for 72 hours. But here the contraindication is ischemic heart diseases. This should not be given to the patient of ischemic heart diseases and peripheral vascular diseases because of its vasoconstriction effect. And the other alternative therapy of terlipressin is octreotide, in the countries where terlipressin is not available, this octreotide should be used. Now come to the band ligation. This is widely used initial procedure for the stoppage of bleeding. As you can see in this picture, the site of bleeding should be identified with the endoscope, and then contact should be made between the ligator and varix in the next step, and then suction is applied to draw the varix into the ligator lumen or the cup of the endoscope, which is cup is present at the lower end of of the endoscope. Then O-shaped ring is released around the neck of the varix, and then hemostasis finally achieved. That is, bleeding is stopped in 80% of the cases. And this repeated after every 2 to 4 weeks until the obliteration of varices. But here the chances of, as you can see, the chances of esophageal perforation are very low, and there are low chances of stricture formation. So this is a safe procedure as compared to other procedures. This is the best method to stop the bleeding. Give this patient proton pump inhibitors like omeprazole or esomeprazole to prevent the secondary bleeding from banding induced ulcers. Now come to the second procedure, that is sclerotherapy. This is not widely used and nowadays replaced by the band ligation. In this procedure, a sclerotherapy or sclerosing agent should be given or injected via endoscope into the varices. This sclerosing agent is thrombin, or it should be cyanocrylate glue. But here the side effects are the esophageal perforation chances are much more higher, as well as more chances of stricture formation. The side effect is also severe side effect is that the patient may develop the pulmonary embolism by this cyanocrylate glue. And this procedure is now used in gastric varices, because in the gastric varices band ligation is less helpful nowadays. In this procedure, through the endoscope is inserted, and which has injectable needle, as you can see in the picture. Then this inject through this injectable needle, sclerosing agent is directly enters into the esophageal or gastric varices. Now come to the next procedure. If the sclerotherapy or band ligation fails, then they perform the next procedure, which is balloon tamponade. It is used in life threatening procedures when the endoscopic management fails or which is not available. In this procedure, a Sangsten Blackmore tube is used. As you can see in the picture, this tube on the upper end has four openings. One is for the gastric balloon port, other is esophageal port, and the third one is gastric aspiration port, and the fourth one is for esophageal balloon port, through which the air is injected. And this tube has two balloons at the lower end. One is for the esophagus, and the lower is for the gastric balloon. And then air is inflated into these tubes. After the inflation, it presses the blood vessels and ultimately reduces or stop the bleeding. Now its presence of this tube into the stomach can be checked by the stethoscope by placing it on the upper abdomen, and then introduced air into this tube. And the air levels should be 200 to 250 ml in gastric balloon. If you are using the esophageal balloon, then it should be deflated after every 3 hours to prevent the esophageal mucosal damage. This procedure always stops the bleeding. It should be performed only if the sclerotherapy or band ligation fails. The other procedures are TIPS, that is transjugular intrahepatic stent. In the stunt in this procedure, the stunt is placed between the hepatic and the portal vein, and a new pathway is created. Due to this new pathway, the intrahepatic pressure reduces, intrahepatic resistance is decreased. As a result, it reduces the portal hypertension. It is very effective for esophageal and gastric varices, but here the side effect is very dangerous, that is hepatic encephalopathy chances are very high in case of transjugular intrahepatic shunt. Now the last procedure is esophageal transection. In this procedure, the surgical transection of varices occurs, but the mortality rate is very high, and this procedure is applied only when all the other procedures failed. Here, the secondary prevention of variceal bleeding. In the secondary procedure, now come to the secondary prevention of variceal bleeding. In the secondary prevention, give the patient's beta blocker to prevent the recurrent bleeding, and then enter this patient into the endoscopic band ligation therapeutic program. And this band ligation should be repeated after every 12 to 24 weeks until the obliteration of varices occur. So this was whole about the variceal bleeding. Thank you so much for watching this video.